This podcast provides general information, not a substitute for professional medical advice. Please consult your physician for personalized guidance.
Welcome back to Psych Rounds. We are back today with Dr. Roger McIntyre. He has done extensive research in the field of bipolar disorder, and last time he gave us a really good introduction to bipolar disorder and talked about the nosology as well as some of the diagnostic criteria, and we are very glad to have him back today. Today we'd like to focus on some of the exciting breakthroughs in the metabolic focused pathophysiology of this illness, and we'd like to talk to him about some of his work. Specifically, he's done things like using GLP-1 agonists like Victoza, also known as liraglutide, in the treatment of bipolar disorder. So Dr. McIntyre, I'll let you take it from here.
Well, it's really such a pleasure for me to speak to this topic. And I think this topic especially is not just interesting, but I think it's extremely opportunistic with the respect to providing people living with bipolar, not just a new therapy, but there's a concept which we call mechanistically informed therapy. So academics like just to make words up that sound smart. It's not uncomplicated. It's not that complicated. All it really means is if we can figure out what's causing this problem, then we're in a better position to cure this problem. And all of our treatments have been really given empirically, just to give it to people. And if their symptoms go away, great. But I think we all agree that it would be better to get under the hood, so to speak, what's going on inside the brain, learn more about the mechanism, and from that inform the therapeutic. And I like to use the phrase GDP, or the acronym GDP. Now, that usually means gross domestic product. We know that mental illness adversely affects the GDP, for sure, but it also affects the other GDP. That's genesis, differentiation, and plasticity of neurons. In other words, what we do, the literature is pretty clear that in the brain, at the molecular and cellular level, there's something wrong with neurogenesis, neurodifferentiation, neuroplasticity, GDP. Consequently, the synaptic strength is compromised. Now, what's interesting is that lithium has been shown to reverse each of these problems in neurogenesis, differentiation, and plasticity. And we went on the lookout for any therapeutic that may be able to positively influence GDP. Well, light bulb moment, we then landed on GLP-1s. I always say that GLP helps GDP. And what we've learned is GLP-1s and their related compounds called GIPs, glucose insulinotropic polypeptide, these are drugs, these are analogs of the naturally occurring extended 4 that have become, quite frankly, almost cult-like phenomenon, thanks to the Kim Kardashian phenomenon. But they're so well known now with respect to their anti-obesity and anti-diabetic effects. And I think just what everybody hears about this now on the evening news, these drugs. But in addition, what is not as well known is that these drugs have very relevant brain penetrance. And when they're in the brain, what do? Interesting. They have an effect on GDP. They increase neurogenesis, differentiation, and plasticity. Along with that, they have a neuroprotective role, protecting the brain against insults like inflammation, oxidative stress. And they also have an anti-apoptotic role. That is, they tend to keep those cells alive longer. So they grow them, they differentiate them, mature them, and give them a longer lifespan. That sounds like pretty cool to me. So from that platform, we then looked at these drugs in people living with bipolar. You know what we found? We found they get into the brain and they increase the strength, the connectivity of the circuit, the networks in the brain. And when people are experiencing this or having this effect happen as measured by MRI, what we also observed is on pencil and paper testing and on their own objective testing, their cognition was improving, their mood was improving. So this is mechanism-guided therapeutics. And what's interesting, by the way, just parenthetically, the glucagon-like peptide analogs, they're also being looked at in other conditions like Parkinson's, Alzheimer's, brain injury, stroke, alcohol use. So I think what we're talking about in psychiatry broadly are therapeutics that share a convergent mechanism around neurogenesis, differentiation, plasticity. And from that, we say, guess what, folks? We may have transdiagnostic application. My world is mood disorders, and the rationale for us to consider repurposing GLP-1 and or GIP-GLP combination, drug called tirzepatide, is informed by this whole body of literature implicating disturbances at the molecular and cellular level. It's very, very cool. And I hope it's actually something very groundbreaking for patients.
Yeah, so Dr. McIntyre, you touched on these GLP-1s, which you mentioned have the Kardashian effect. I like that term. Very, very popular in the media. We're seeing that covered almost every week in the news now. My question is this something that we only see with the GLP-1s in terms of the alteration of or treatment potentially of bipolar disorder? Because standard practice, and correct me if I'm wrong, used to typically be prescribing sometimes metformin, which back in medical school, we all kind of learned it inhibits the hepatic gluconeogenesis, opposes glucagon, does these things. Does it still have beneficial effects in bipolar disorder, or are you seeing more of a result with these GLP-1 medications?
It's really interesting. There's been it's almost like there's been a history where diabetes and psychiatry have been connected at the hip, in the sense that from an epidemiologic and from a clinical perspective, these disorders extensively overlap. And when you look at the therapeutics, there's a long history of therapeutics in psychiatry getting repurposed in diabetes and vice versa. Many would know the drug called memantine. Memantine is an NMDA uncompetitive antagonist. We know it best in the world of dementia and major neurocognitive disorders. That's where it's used. It was actually originated in 1968 by Eli Lilly as a treatment for diabetes, but it got repurposed as a drug for dementia. And when you think about, what are some of the most common risk factors for dementia? Well, insulin resistance and its alterations in the genetics for lipid metabolism, so-called LDL metabolism, so on. There's always been this history. And metformin has been absolutely considered as not just a treatment to offset weight and to offset psychotropic-induced weight in people with bipolar, but also as a effort to improve response to antidepressants. Hold on, what am I saying? What I'm saying is that metformin not only insulin sensitizes in the sense of improving, glucose parameters and improves your weight, but it may also convert a non-responding bipolar patient to a responder, because in the brain, insulin like GLP-1 has those effects on GDP. That is genesis, differentiation, plasticity. And what's so cool is that when you have an impairment in insulin signaling, of which at least half of people with bipolar do in the brain, metformin is kind of like STP oil treatment. It kind of ignites, it allows the drug to work better. So metformin is a really interesting proving the concept that something aberrant is taking place in bioenergetics of the brain. And this has provided the impetus to look at things like diet. Ketogenic diet is getting a lot of interest now in psychiatry. Could it be affecting the brain positively? Yes, no. If it's yes, is it doing through insulin resistance, anti-inflammation, antioxidants, anti-apoptosis? What about exercise? A pill that nobody wants to swallow. But exercise, could that have that effect? The other part is really, really interesting and related is sleep. Because all you need is a couple of hours of sleep disruption and it affects your insulin signaling, the GLP-1 signaling. And so is it possible that chronotherapeutics like CBT insomnia or orexin antagonists, are they possibly helping mood through some of these metabolic parameters? Not without our interest that orexin antagonists, these are drugs better known as sleeping aids. These drugs are being developed as antidepressants in phase 3. So there's a lot of crosstalk here with inflammation, with metabolism, and with the underlying neurobiology that we implicate as subserving the pathology you and I call bipolar disorder.
Yeah, and since we're on the topic of metformin, I quickly wanted to give a shout out to Dr. Cynthia Culkin. I think she produced an article last year called the TRIO-BD study, where she found that metformin was effective for bipolar depression with actually a fairly large effect size. And since we're on the topic of metformin, it's also a very popular medication in the longevity community. And Dr. McIntyre, I've seen some of your talks on YouTube where you talked about how bipolar disorder actually ages the body. So my question is, we're talking about how metformin might be effective for certain aspects of bipolar disorder. What about other things like caloric restriction, fasting, and even something like resveratrol? Can these things also help patients with bipolar disorder?
Oh, that's a great question. I think these are just really interesting, testable, viable, coherent hypotheses. I often ask the question, what is the most effective intervention to slow aging in animal? And you touched on it. It is caloric restriction. And then I asked the second question, what's another way you can slow aging is in resveratrol, which is in the red wine. So basically, stop eating and drinking red wine seems to be the solution to live longer. That's kind of a concrete interpretation, but it's really cool because it appears as though, it's people asking, well, how does this all work? Well, when you take in caloric load, obviously we need calorie, obviously we need energy. So no one's saying don't eat. The question is about the frequency of eating and the interval of eating. And the metabolic machinery has byproduct, and the byproduct includes, among other things, reactive oxidative species, nitrogen reactive species, as well as inflammatory markers. And consuming too much, consuming high glycemic, consuming too much calorie can lead to a accumulation of this. So I think what you're touching on is really interesting insofar as, is there a way to calorically restrict? Someone should look at that. The resveratrol is interesting. That actually is reducing inflammation through toll-like receptors, the inflammasome, basically the signature of our inflammatory network. What metformin and what resveratrol and possibly what diet restricting food also do is they have effect on a set of proteins we don't talk about much called sirtuins. And sirtuins are proteins relevant to cellular aging. And so we always talk about telomeres, how your telomeres get shorter and smaller as you get older and older. It's a great biomarker. People use it a lot. It's easy to do. But there's other markers and other facilitators of cellular aging like sirtuins. And what's really interesting is that metformin, diet restriction, and or resveratrol have very salutary or positive effects on sirtuins. So there is, in fact, there's not just one molecule indicative of aging, there's others like sirtuins. And so it's a very interesting story. To back up maybe a step or two, there's no question that when you look at the brain in people with bipolar disorder, there is premature cell loss, so-called apoptosis. So what we want to do is, yes, we want to create new brain cells. Neurogenesis sounds like a good thing to me. And then you want to differentiate them and specialize these neurons, give them nice big dendrites, and you want to have greater synaptic strength. That makes good sense to me. But you want to keep these new cells alive. So you also want to inhibit the pro-apoptotic machinery, and you want to, in fact, reduce the neural vulnerability. And that's where a lot of these things come in, because we talk about sirtuins or resveratrol, diet restriction. These things have effects not only with respect to genesis and trophism, but they also have this sort of effect on the other side, that is keeping cells alive longer. And we talked about inflammatory aging in bipolar in the past. We think that many of the premature onset of chronic diseases in bipolar, E.G., heart disease, hypertension, arthritis, Alzheimer's, this is indicative of an underlying premature aging process. One final comment, let's not forget lithium. Lithium's been around since the Big Bang, but lithium was first isolated in 1834. A Swedish chemist, 1817, a Swedish chemist named Arfredson isolated it, and it started being used in the 1830s. Lithium is sort of such a magical salt. Among other things, what does it do? It seems to inhibit some of the apoptotic machinery. It's anti-inflammatory. It's immune modulating. It has a viability enhancing effects on neurons. I mean, this is remarkable what it has. So I think that we lithium still remains not just a important mood stabilizer. It's still the first line for patients with classic euphoric mania, but it's one of the few drugs that we can really say it's targeting the mechanisms, molecular and cellular, that we are putting in the crosshairs as causing bipolar disorder. So lithium is not yet known to be disease modifying, but it's pretty close to being accused of being a mechanistically informed therapeutic. It's pretty close. It's really interesting, the mechanisms it touches on.
And speaking of lithium and telomeres, so we actually did an episode on lithium a couple of weeks ago. And when I was reading the literature, there was a paper that was suggesting that lithium actually might lengthen telomeres in the body. But just to switch gears real quick, so I asked you this question off camera a couple of weeks ago, but I think for the benefit of the listeners, I kind of want to ask it again. So on the other side of the spectrum, we have very metabolically unfavorable medications like quetiapine and olanzapine, which have been shown effective to treat the symptoms of bipolar at least. But do you think that these medications can treat the symptoms but potentially worsen the underlying cause? Because there are other examples of this. For example, giving certain type 2 diabetics insulin might resolve some of their hyperglycemic symptoms, but long-term, it might actually cause them to gain more weight and worsen that insulin resistance and worsen that underlying metabolic syndrome that was causing their symptoms in the first place.
Yeah. I think the point is well taken. I think the question has to be asked, and here's where I land on that. I would land on that I think that I think it would be a fair statement to say, or a fair statement, that in the preferred, not the ideal, just the preferred situation, we want treatments that are able to alleviate symptoms, alleviate suffering, and don't cause metabolic and or weight effects. I don't think anyone's going to dispute that. What we have is what we have. The net, however, is that I do think that the benefit of the treatment still overshadows the cost. Let's start with that. I think it clearly does. It clearly encroaches on the benefit, because I don't meet anyone who wants to gain weight. I don't meet anyone who wants to have diabetes. So clearly it's encroaching on the therapeutic index of some of our treatments like olanzapine and clozapine, just to name a couple. Whether or not it's also amplifying or engendering other effectors that are causative, I don't know that to be the case. It certainly is not an outcome we want. But what's really interesting, I think it really makes the case strong, is that when you look at patients treated with clozapine, which we all agree is the most diabetogenic, the most obesity promoting antipsychotic, what's interesting is that mortality is reduced with that drug, not just from suicidality perhaps, but notably from medical problems. And that's kind of a head scratcher, because that'd be the one you'd probably pick first is the worst offender. So what that tells me then is that, yes, your insulin example is a great one. I think the net is, and I think we all agree, that insulin is a very good treatment for people who need it for diabetes. Yes, it can cause weight gain, but the net is it's going to do a whole bunch of other things that are offsetting that benefit, or that risk. So I think it's about not throwing the baby out with the bathwater necessarily. I think it's about thinking laterally and orthogonally. Can we improve upon? Can we develop new therapies that don't have this problem? That's why I think some of the newer treatments for bipolar that don't have weight gain and or metabolic shift, some of the dopamine partial agonists, the lumateperons, there's a few other drugs that are in development right now, are especially appealing to me, because I think that they don't have the baggage. But so more narrowly, do I think that these drugs that are weight gain promoting and metabolic disrupting, are they amplifying causative factors? I don't think I can say that. I don't know that. I can't say that. Is it something we want? Absolutely not. We don't want that. But the net for now is, it is what it is. And I just think if we can now use this knowledge and say, okay, what is it about these drugs that causes the unwanted? What's causing the wanted? The medicinal chemist has to get in this conversation. Let's develop some new therapeutics that don't have that problem. So that's kind of how I see it. But I'm a little bit concerned when I hear some people in different areas, the media, in public conversation, at conferences, saying that the drugs are not worth it because they cause all these problems. I don't see life that way. I would like to say life is perfect, but I see it a little more nuanced. And I think that, yes, we got a lot of work to do, but I do think they're life-saving therapies, despite the fact they have some of this baggage.
Thank you for that answer, Dr. McIntyre. I want to turn back to kind of theory a little bit. We covered the pathophys from a circadian rhythm perspective previously on our podcast, and I was really interested in this and hearing other podcasts talk about almost this circadian purist perspective. I was wondering in what ways the sort of circadian impacts intersect with the metabolic syndrome or the metabolic effects that you've been describing.
Well, I love that question because I think that for me, as I've tried to identify a nexus, a common point that can intersect so much of what we see in bipolarity. Look, I'm guilty, like anybody else, of wanting oversimplicity and a reductive view of the world. I love anti-entropy, anti-chaos, like anybody else does. And I think that when you come up with a simple reductive explanation, the first person is going to raise their hand and said, "You've overly simplified it. You've missed out this, and this." And I'm going to plead guilty in the first degree. I, however, would say I like the fact that there is such powerful explanatory potential of the circadian rhythm in so much of what we see in bipolarity, whether it be affect dysregulation and or cognitive impairment. So much of that is a direct consequence of ongoing circadian or more chronobiologic disturbance, and one evidence of that is sleep-wake. Another evidence of that is circadian rhythm. And then to your point about metabolics, I don't think it's as well known. They've done these studies in college students where I kind of chuckle, they sleep deprived, which means they get like 6 hours of sleep instead of like 8, which I think is, I'd call that actually a privilege to get 6 hours of sleep. But anyways, but 6 hours of sleep, they disrupt your sleep for like an hour or two, and oh my gosh, this is abusive. And what they find after just an hour or two of disrupted sleep in healthy controls is they find at the receptor level, the insulin receptor, there's impairment in sensitivity. You begin to see alterations in insulin glucose homeostasis with minor perturbations and sleep disruption. Again, half of people with bipolar disorder, 1 and 2, who are perfectly asymptomatic, meet the criteria for a sleep disorder in the DSM. So sleep is so problematic. And then you have the related but different issue. Once you've got excess weight and metabolic problems, trying to correct that while you are sleep disrupted or having circadian problem, I won't say it's impossible, but it gets pretty close to impossible. So there's clearly an activation of the stress response system, not just being the autonomic, the inflammatory, the HPA systems, wherein you're getting energy conservation in a stress state at which sleep disruption and circadian shift is a major stress state. So I think it brings together much of this, and I think it's a big, big player. This is why I've always believed that weight management, medical comorbidity management, bipolarity, is not only about the diet, exercise, where applicable GLP-1 or where applicable other more focused interventions, weight management, contingency, and so on, but also it does include sleep. And I just think that I think it really is the nexus. I've often said, by the way, that if someone was to waltz into the APA head office in Washington and say, we want to make a proposal that bipolar disorder is now categorized as a sleep disorder, I wouldn't agree with that, but I would certainly say, I see your point. It's just so, I've never met a patient in my entire life who doesn't have some issue with sleep. And I think its role in inflammation and metabolism to this issue of metabolic comorbidity is well and amply documented. So I think it could be a case here.
And Dr. McIntyre, as we get close to wrapping up here, I just want to give our audience some more of a flavor of optimism as well, too. So the question for you is, where do you see the future of treatment heading? Because, we look at some of the movements in the pharmaceutical industry, and there's a lot of talk of some more metabolically friendlier agents, things like muscarinic agonists, ketamine, psilocybin. Where do you kind of see the future of treatment heading for our bipolar patients?
Yeah, I think this is a great way to end, because for me, as I look back at the last 30 years since I've had the privilege of being part of this community, and I turn the other direction and look forward, and I look, where this field's going, I think the field has got nothing but to be optimistic. It's just such an optimistic time. Let me just give some guiding principles. You touched on some of the glutamatergic dissociatives like ketamine, the serotonergic psychedelics. I think to back up, I think we're looking at treatments that are more mechanistically informed. Now, somebody's going to say, well, who cares? Why would that matter? Well, because we want to one day say that our treatments are modifying the disease, maybe even cure it. Why can't we say that? And we're not going to be able to say disease modification or cure unless we know what the mechanisms are. You mentioned xanomeline, or you alluded to it. I want to for partial agonism. The future, we're working on kappa opioid receptor antagonists. We got a bunch of NMDA derivatives, and so on and so on and so on. It's just a carnival of new treatments now that have come to play. And so I think that's hopeful. A second part about what I think is hopeful is I think the days are over where it's going to be status quo acceptable that drugs should take 4 to 8 weeks to work. One of the advantages of the psychedelics and ketamine is they work rapidly. Dextromethorphan works like within a few days to treat depression. This is the future of psychiatry. Thirdly, you go see a psychiatrist or a mental health care nurse or what have you, PA, DO, whatever. They tell you to take your pills every day. Well, that may still be the case, a chronic dosing paradigm. Maybe some of these treatments of the future are going to be an intermittent dosing paradigm. That's what it is for ketamine. That's what it is for CBT. That's what it is for ECT. Maybe our drugs don't need to be taken every day. Wouldn't that be kind of cool? So rapid acting and take them intermittently. That's it. But I also think what's going to be really, really interesting and really, I think, so promising, the pharmaceutical industry has been really, it's the way the pharmaceutical, I've had the privilege of working with the pharmaceutical industry in many ways. And I know that they have, there's this, they're not doing that great public relations. I'll say it that way. And I'm aware that they have a certain kind of reputation. But I would say this, it is good business to have therapeutics that are revolutionary. Look what GLP-1s are doing. Now, GLP-1s are changing the management of diabetes and obesity that we've never seen before. Now, they're also commercially very successful, so these are not mutually exclusive. It is good business to have something that's revolutionary. And there's a lot of interest now in the private sector, more than I've ever seen in my career, in taking some of these nifty little molecules in bipolar and depression and taking them to rigorous, adequately well-controlled trials. So I think the next 3 to 5 years, you're going to hear a lot of new therapeutics you haven't heard a lot about before. We're going to see new dosing paradigms, more intermittent, rapid-acting treatments. And the other part about this as well is I think you're going to see much more of the digital, not just ways of monitoring, surveilling your illness in the way that you agreed to, of course, but also as a way to help manage your illness. I think that's going to be much more the future. And one final comment will be, is that I think that because of the digital, because of the capability, the biggest gap we have in bipolar disorder today is the implementation gap. People are not getting treatment that align with the best evidence. So I think we're going to have now the big brother, maybe Orwellian, but the big digital that's going to allow us to know, right? Just like you drive your car into your driveway, it already tells you when you haven't fastened your seatbelt, bing, 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 bing. That's the kind of announcement we need when the patients are getting treatments that don't remotely align with what the evidence is. So we need better detection, close implantation gap, we need to have disease modification, intermittent, and we need to have rapid acting treatments. And all of these aspects are being simultaneously discussed right now in the private sector. I think it's very promising.
All right. Well, thank you, Dr. McIntyre, for joining us on this very important discussion. We appreciate you coming on today to share your expertise in this field. It is greatly appreciated.
Great to be with you guys. And, it's been fun having this discussion. And as you guys know, I have a journal club on X, or the old Twitter, Roger S. McIntyre, MC. It's all one word, Roger S. McIntyre, MC, all one word. People can feel free to join me and let's keep the conversation going.
For our listeners, we will put that feed right in the bottom of the episode description for you guys. Thank you, everyone, for listening to Psych Rounds, and have a great weekend.